A very good evening to all my dear friends, and I hope all of you are doing well, all set for your exam, doing your preparation with full enthusiasm, with full sincerity, and putting in your hard work over there. A very good evening to all of you, and a warm welcome to today's session, in which we are going to discuss, as you know, 25 most important clinical questions in ophthalmology, which will simulate the type of the questions we expect you to get in the exam beta. So this session, I'll try to make it most productive session for you. During this session, we will try to cover the high yield topics, give you a good revision in ophthalmology, and make you familiar with the type of the questions, with the images, and how to attempt them. A very good evening. How are you all doing? So, are we all set for the session to start? And I will like you to be interactive in this session, okay? So that all of us can get a best benefit out of this. Okay. So the type of the questions which we are now going to practice will be a mixture of the questions in which there will be clinical case scenarios, there will be images, a combination of this to cover up everything. Okay, perfect. So let's start our session beta and let's begin with the first question here. Okay. All right, just give me a minute here to check that it's moving all good here. Okay, just a second bit. I'm just kind of connecting it. So I did check it once. It was all good. Just a small reconnection needs to be done. Okay, here we are, all set now. Yes, perfect. So that gives us some time to get ourselves ready. Okay. All right, dears. So you can see the first question here on the screen. So it's a clinical case scenario question with an image. So I always tell you guys that when we attempt the clinical case scenario questions, try to look at all the keywords which are there in the case statement, which can help you to clinch the diagnosis. Okay. So read the case statement carefully, look at the every word, try to get the proper information there. Okay, so what is this question letting us know? A young patient presents with severely painful red eye. So the age group of the patient is a young patient. What are the symptoms which we are getting here? A severely painful red eye. Okay, so this is important to note. And blurring of the vision. So there is a blurring of the vision as well. On examination, the following findings they are seen. So there is a clinical picture shown you here. Which of the following is not the likely risk factor in this case? So we have to make a first of all diagnosis that what is this condition. Okay. Severely painful red eye with blurred vision. So there are a few conditions in which you get this kind of picture, that there is a painful red eye with decreased vision. Okay. These conditions, they include your corneal ulcers, especially the infective corneal ulcers. That can include acute angle closure glaucoma, that can include acute anterior uveitis. Now, what is the actual thing? We will get to know from the image here. So what do we see in the image here, beta? Just to go through the image for everybody's information. So we are seeing a red eye here. All of you are able to see a red eye here, and very characteristically you are able to see that there is a lesion on the cornea. There are infiltrates on the cornea which are in the form of a ring. Alright, which are in the form of a ring. So this is your typical ring ulcer. This is your typical ring ulcer. Now, when they say severely painful, so as all of you must be remembering that there are infections which are very severely painful, which are caused by acanthamoeba, So this is your acanthamoeba keratitis. Agree? Why it is very severely painful? Because there is not only involvement of the corneal tissue as such, there is also involvement of the corneal nerves, which leads to keratoneuritis. So that's why it's a severely painful ulcer. So we have made the diagnosis. Now coming back to the question. So all of you know that what are the risk factors for development of infection with acanthamoeba. So mostly it is used because of the use of the soft contact lenses when they are used in unhygienic manner, when you are not taking the proper precautions with the use of the soft contact lenses. Okay, so which includes cleaning of the soft contact lenses with tap water or with river water, shearing of the contact lenses, taking shower with contact lenses on. Even trauma with the vegetative matter can also lead to acanthamoeba keratitis, because acanthamoeba is a free-living protozoa. Okay. However, trauma with the metallic object has no particular risk increase for the development of acanthamoeba corneal ulcer. So all of you are very right here. Trauma with metallic object is the answer, because that is not the likely risk factor for development of acanthamoeba keratitis. Okay. So here I would like to mention about the option D, beta. I would like to mention about the option D. Vegetative matter trauma, the highest risk is development of fungal keratitis. Okay. So you are very right. Leaf injury, tree twig injury, vegetative matter trauma more likely to cause fungal keratitis, but this is also one of the risk factor for acanthamoeba as well. Okay, so if something like that comes, do not get confused that why there is vegetative matter for acanthamoeba. But yes, soft contact lens use in improper manner is the most important risk factor for acanthamoeba keratitis. And of course, how we will differentiate that whether it is an acanthamoeba or fungal keratitis, if there is history of vegetative matter trauma, it will be by the clinical signs of the corneal ulcer. So you know acanthamoeba is causing this typical ring-shaped ulcer, severely painful, whereas in comparison to acanthamoeba keratitis, fungal ulcers, they are not severely painful. They have their typical signs of dry raised infiltrates, feathery margins, and satellite lesions with big hypopyon. Okay, whereas these features, they are not present in acanthamoeba keratitis. Okay, right? Yes, that's right. Very, very good, beta. I'm very happy that you, all of you know, are remembering all the key points which we need to know. Now, in acanthamoeba keratitis, let's just again revise two more things related to acanthamoeba, which actually came in your last INI CET exam as well, beta. So, to confirm the diagnosis of acanthamoeba keratitis, remember, to confirm the organism, we always take corneal smear and we do a culture of the organism. Now, what stain is used to identify acanthamoeba on corneal smear? So the stain which we used for acanthamoeba is beta calcofluor white. Calcofluor white. Okay, so that is the specific stain for acanthamoeba, right? And what is the culture media which is used for culturing acanthamoeba? That is E. coli enriched nutrient agar. E. coli enriched nutrient agar. Okay, so this is kind of some more information which you should remember related to acanthamoeba keratitis. Okay? Okay? Yeah, so all right. Yes, KOH is for, very right, for fungus. Gram stain is for bacteria. For bacteria, we can use the blood agar. For culture, for fungi, we use the Seborrhoeic dextrose agar. All right, beta? That's great. That's great. Okay. So this covers your information related to most of the infective corneal ulcers which we have done. Moving to the next question, beta. Moving to the next question here. A young man presents with high intraocular pressure. A young man presents with high intraocular pressure and following slit lamp findings. Which of the following will be seen in this case? Okay, so the only information which is there is that there is a patient who is of younger age group and there is high intraocular pressure. Okay, and then coming back again to the slit lamp image which is shown here. The slit lamp image which is shown here. So what do we see in the slit lamp image here, beta? What we are seeing over here is cornea is clear, there is nothing in the cornea, okay, but when you are looking at this iris, you see this red reflex which is coming from the areas of the iris as well. Why? Because there is iris atrophy. There is iris atrophy here, and this type of the iris atrophy is leading to what we call as transillumination defect. We call it as transillumination defect. Why this iris atrophy is occurring? Because pigment is being released. Pigment is being released in this particular condition, and this pigment which is being released from the iris is getting deposited on the corneal endothelium, leading to formation of Krukenberg spindle. And when it gets deposited in trabecular meshwork, it leads to increase in the intraocular pressure. That is why this is called pigmentary glaucoma. It's a condition which is called pigmentary glaucoma, beta. And pigmentary glaucoma is more common in younger age group, especially in younger males. Okay, it's a secondary open angle type of the glaucoma in which you will see iris atrophy leading to transillumination defects, Krukenberg spindle, high intraocular pressure. Okay, so awesome. All of you are absolutely right in your answer. All of you are telling me absolutely the correct answer. Okay, now coming back to the other choices, aqueous misdirection, as you see, there is which is also called as a malignant glaucoma, in which the aqueous, rather than flowing into the anterior chamber, is now misdirected towards the vitreous cavity. So in cases of aqueous misdirection, what we see is a shallow or flat anterior chamber. Okay, and there is nothing related to pigment deposition or anything like that. Okay. Target sign is seen in the cases of pseudo exfoliation glaucoma or pseudo exfoliation syndrome, like here. Okay, so this is a slit-line image in a case of pseudo exfoliation syndrome. And in pseudo exfoliation syndrome, as you know, there is a deposition of white fibrillary material on the lens surface, on the pupil margin, and in the trabecular meshwork. So in these cases also there will be high intraocular pressure. There will be an appearance of pseudo exfoliation on the lens surface, which appears as a target sign, Okay, and the choice D was talking about iris neovascularization. Iris neovascularization is seen in the cases of conditions in which there is retinal ischemia, and iris neovascularization is also called as rubeosis iridis or neovascularization of iris. So when this is present, that leads to neovascular glaucoma. Most common cause of neovascular glaucoma is your advanced proliferative diabetic retinopathy. So question statement was not mentioning anything related to diabetes, and slit lamp picture was of course not like this. So if this slit lamp picture is there when there is iris is showing you new vessels all over, then you will mark neovascular glaucoma as your answer. ठीक है जी? Right? So this covers lot of your secondary glaucomas, which are again an important topic, because previously the question has been asked on pseudo exfoliation, on neovascular glaucoma, malignant glaucoma as well, and again in the recent exams there has been question on the pigmentary glaucoma, better related to Krukenberg spindle and so on. All right? Okay. Easy to remember? Let's do another question here, which is again going to give you an idea about another important condition which they ask in the exam beta. All right. Okay. So friends, coming to the next clinical case scenario question. So let's read the question statement. A young boy presents with decreased vision. So there is decreased vision. Again, the age group is a young boy. Hazy cornea in the left eye on examination. There is also bulging of lower lid on looking down. So lot of things they have been told to you. Decreased vision in a young person. There is also haziness of the cornea, bulging of the lower lid on looking down. He gave history of use of RGP lenses. RGP are your rigid gas permeable lenses beta. RGP is rigid gas permeable lenses in both eyes. So which of the following is the likely diagnosis in this case? Okay. Now with the history, as you know, there is one condition in which cornea has become conical, so that when the person looks down, there is bulging of lower lid. We call it as Munson's sign. All right. So even this information is enough to give you that this is a case of keratoconus, right? RGP lenses are used to correct irregular astigmatism in keratoconus. Now, there is a hazy cornea. So, why there is hazy cornea, or when the hazy cornea occurs in cases of keratoconus? When there is complication of, as you know, what we call as corneal hydrops. Corneal hydrops beta. What is corneal hydrops? If you remember, in the cases of keratoconus, what is happening? Stroma is becoming thinner and thinner. Okay, there is thinning of the corneal stroma. Stroma is becoming thinner and thinner, and there can occur episodes in which there is sudden rupture of the descent membrane. We know descent membrane is a very strong elastic membrane, but sometimes the cornea has become so thin and stretched out that there is sudden rupture of descent membrane. So descent membrane, when it ruptures, that leads to hydration of the cornea. The fluid from the aqueous gets imbibed into the stroma, which leads to stromal edema. Now this is most of the time a sudden episode. So that will lead to haziness of the cornea, that will lead to further decrease in vision, and even pain, because the cornea is becoming hydrated very acutely. Okay, so this is a complication which can occur in cases of keratoconus. So this is what is this case statement was discussing about. So what is your diagnosis here? So the likely diagnosis here is corneal hydrops in keratoconus. Corneal hydrops in keratoconus. ठीक है जी? Right? Now coming to the choices, how to exclude the other choices. So sometimes when you are not very sure about the actual choice, you all know that if you exclude the other choices, many a times you can get a right answer. Right? So acanthamoeba keratitis. So in acanthamoeba keratitis, there is no reason to have a Munson sign. All right, and there can be decreased vision and hazy cornea, of course, but then it's more common in soft lens contact lens users. Okay. Fuchs endothelial dystrophy. So it's a type of endothelial dystrophy which is more common in elderly patients, beta. Fuchs endothelial dystrophy is common in elderly patients, mostly elderly females. Again, in these cases, there is hazy cornea because of corneal decompensation, but there won't be any history of RGP lenses or Munson sign. And what is Murren's ulcer? What is Murren's ulcers, beta? Murren's ulcer is a type of peripheral ulcerative keratitis. Right? It's a type of peripheral ulcerative keratitis in which an autoimmune condition in which there is corneal thinning, but that's occurring in the peripheral part of the cornea, and it's a progressive condition, of course, but then the typical case history as you have gotten it, it's your corneal hydrops in keratoconus. Okay? Right. Yeah, very nice. Dr. Vivek Kumar. It's also called rodent ulcer in the cornea. Okay, perfect. Every one of you, I'm so happy that your concepts are right, your fundamentals are clear, and you are going to continue this in the exam. I'm very hopeful. Okay. So just to kind of remind you how the Munson signs looks like. Okay, so this is not the same patient because the picture view which you are seeing here is of the right eye. So just to mark it, because sometimes you get confused. But here, this is our patient which we were talking in the clinical case scenario question. As you see, there is a Munson sign here, and this left eye is also showing haziness in the cornea, which is corneal hydrops. Okay, and Munson sign is present on the other side as well. And as you know, keratoconus can be asymmetric, so it's more severe in the left eye. Okay, beta, right? Okay, so this was a clinical case scenario question related to your keratoconus. And if you want to tell me the other treatment options for keratoconus when it advances, because there has been questions related to that as well. So what are the other options? In early stages, to correct the irregular astigmatism, you are using RGP lenses, right? And when it's a progressive one, you are doing, yes, Dr. Weber, very nice, you are doing, just to kind of highlight the treatment options, is treatment options for keratoconus we are talking about. Okay, C3R, you are very right, collagen cross-linking C3R or CXR for progressive one, and then you can do Intax, the intrastromal corneal ring segments when there is progressive thinning of the cornea. Okay, right, and it may also require penetrating keratoplasty, when because of the recurrent episodes of corneal hydrops, there is corneal scarring, then you might require penetrating keratoplasty. Correct? Yes, very nice, Sunny, Nitesh, Abhi ready, perfect. Okay, and just an additional information here, when there is acute episode of corneal hydrops, then what do? So in these cases, we can inject intracameral means into the interior chamber, a bubble of gas. Okay, we can inject an air bubble or gas bubble so that the hydrated cornea becomes dehydrated. ठीक है बेटा? So this is not required at our level, but corneal hydrops we can inject a small gas bubble or air bubble in the interior chamber, which will help in reducing the corneal edema. ठीक है? No, here we will not call it as intravitreous beta. यहाँ पे we call it as intracameral. Intracameral, that is in the interior chamber. Great. Okay. Let's move on to the next question, beta. Let's move on to the next question here. Okay. So what is the clinical case scenario over here? Another clinical case scenario. An elderly patient presents with mild ptosis and myotic pupil, okay, in the right eye. So patient's age group is elderly patient. Patient is having mild ptosis. Ptosis means the drooping of the eyelid. Myotic pupil. Myotic pupil means pupil is constricted. Pupil is constricted. There is dilation lag in the affected eye and history of anhidrosis. So which of the following is the likely site of lesion in this case? Absolutely right. So you guys are like right hitting the bull's eye, beta. So mild ptosis, miosis, anhidrosis, dilation lag, everything is mentioned here. So this is a case of Horner's syndrome. So this is a case of Horner's syndrome, and we know Horner's syndrome is an oculosympathetic paresis or palsy. Okay, so it's your sympathetic chain which is affected. The site of the lesion is in the sympathetic chain, more commonly in the cervical area. So as you told me, C is the right answer for this question. Okay. Third cranial nerve is carrying the fibers for the sphincter pupillae, parasympathetic fibers. Cervical ganglion, they are again, it's a parasympathetic ganglion. So these are part of the parasympathetic system, you can say. Pretectal nucleus. Pretectal nucleus is again a part of the parasympathetic because it's controlling the pupil reaction, direct as well as the consensual. सब जगह पे ये syndrome आ ही जाता है बेटा, easy, बल्कि we all know about this. जब ऑलरेडी हमें हॉर्नर सिंड्रोम का पता है तो बढ़िया है, ठीक है? Okay, so just like this is how the Horner syndrome looks like, beta. As you can see in the right eye of this patient, so what do you notice here as comparison to the left eye? There is mild ptosis, okay? There is mild ptosis. See the size of the pupil here. This is smaller than the pupil in the other eye, okay? Miosis, and if you check, this patient will have a dilation lag, that when they go to a dark room, their pupil takes time to get dilated. That is called as dilation lag, and there will be also anhidrosis or loss of sweating on the affected side, beta. So this is how your Horner syndrome looks like. Okay? And you remember in your previous year questions, there was a question related to Pancoast tumor causing Horner syndrome. So Pancoast tumor is your tumor of the apex of the lung, which if compresses the cervical sympathetic chain, as we were discussing, can lead to Horner syndrome. ठीक है, yes, apparent anophthalmos beta. Okay, very nice. Muller muscle is the one which is getting paralyzed, leading to mild ptosis here. So this is apparent anophthalmos. Apparent means it looks like that eye has gone inward, but not the actual one beta. ठीक है जी, right? Great. And just a quick idea about the pupil reflex beta otherwise. So you know, when the light falls on the retina, that is the afferent part or the sensory part of your pupil reflex. So optic nerve carries not only the fibers for the vision, but it also carries the pupillary fibers. But these fibers then they go to the pretectal nucleus, and from there are internuntial neurons which connect them to Edinger-Westphal nucleus. Okay, and then the efferent fibers, they are taken by the oculomotor nerve or the third nerve to the parasympathetic ganglion, which is your ciliary ganglion in the orbit, and then from there the fibers, the parasympathetic fibers or postganglionic fibers, they reach the sphincter pupillae. Okay, so this is about the other choices which were there. Now any point of the time, like different areas, if they are affected, so if there is a lesion in retina or in optic nerve, okay, so if there is any severe retinal disease or a lesion of optic nerve, so that will lead to a condition called RAPD, relative afferent pupillary defect, because the sensory part of the pupil reflex is gone. Okay, so that can lead to RAPD or Marcus gun pupil. Okay, if the lesion is in the pretectal area, if the lesion is over here in the pretectal area, so there is a light near dissociation, and this is called as AR pupil or Argel-Robertson pupil, in which light reflex is absent but accommodation reflex is present. Okay, if the lesion is at the level of ciliary ganglion, parasympathetic ganglion, that can lead to AD's pupil. Okay, and if the lesion is in the third nerve area, because third nerve area is carrying the fibers for pupillary constriction, so in those cases the pupillary reactions will not be present, so pupil will not constrict. Okay, right? So yes beta, Argel-Robertson is, yeah, you are very right, when the lesion is in the pretectal midbrain area. Okay, so this is kind of revising the other pupil abnormalities which can be there. All right, ready to move ahead beta? Okay, perfect, let's go. Moving on to the other clinical case scenario beta, moving on to your another clinical case scenario. Okay, let's read the question statement. A patient presents with fever, pain and lid swelling. Okay, so what are the symptoms with which the patient is presenting? Fever, pain and lid swelling. A diagnosis of orbital cellulitis is made. So already they have told you the diagnosis. So after ocular examination, ophthalmologist decides that this is a case of orbital cellulitis. Now, which of the following is not a true statement about orbital cellulitis? Now let's see what are the statements. Option A, ocular movements are normal. There is painful proptosis. Source of infection is mostly an ethmoidal sinusitis. Intravenous antibiotics, they are given for the treatment. Okay, so coming to the statements one by one, let's go from below to above. Orbital cellulitis is an ocular emergency beta. Remember, it's one of the conditions which fall under the category of ocular emergency. So here the infection can rapidly spread from the orbit to the cavernous sinus, causing cavernous sinus thrombosis, to the brain, causing intracranial abscess. So this has to be dealt by intensive intravenous antibiotic. So this is a true statement. ठीक है. Source of infection is mostly ethmoidal sinusitis because of the proximity of the orbit with the ethmoid sinus and a thin wall of the ethmoidal sinusitis. So this is also correct. It can also occur after orbital trauma or after orbital surgery or even procedures like DCR, but more commonly through the ethmoidal sinusitis. There is painful proptosis. Very right, because there is inflammation of the soft tissues in the orbit. So there is proptosis, which is painful as well. Ocular movements are normal. Now this is a false statement because there is inflammation, infection, suppurative inflammation in the deeper areas of the orbit, deeper to the orbital septum we call it as. So it's not only the lid swelling, there is also extraocular muscle involvement. There is also involvement of the optic nerve, because of which there will be pupil abnormalities. So extraocular movements, they are restricted. Okay, they are not normal. So this is your right question option to be marked here, as many of you have already told me. That is A. ठीक है जी, right. So it's not only beta painful ocular movements are restricted. Movements, they are restricted. Ophthalmoplegia as we call it as. Perfect. ठीक है, right. So just to show you, this is a like kind of diagrammatic representation to tell you difference between preseptal cellulitis and orbital cellulitis. So in preseptal, as the name is only suggesting, the inflammation is just superficial to the orbital septum. Okay, so infection stays in that area only. So there will be lid swelling, there will be pain, there can be even fever, but then you can see the part which is behind the orbital septum is all normal. So there won't be any proptosis, there will not be any decrease in the vision or pupil abnormality or extraocular movement restriction in preseptal cellulitis. Whereas in orbital cellulitis, as you see here, the inflammation is in the area which is behind the orbital septum. So this whole area is having suppurative inflammation. Extraocular muscles, they are also involved. The soft tissue, the fat is also involved. So that leads to painful proptosis, ophthalmoplegia, diplopia, double vision can be there, pupil abnormality is there, decrease in vision is there. Okay? So please try to look at the question statement, whether they are talking about preseptal cellulitis or they are talking about orbital cellulitis. Okay, right? Okay, perfect, my friends. Moving on to the next question. Alright, so here is an image-based question, beta. Based upon the image, you have to tell me the diagnosis. So what is the diagnosis based on the following findings? What is the diagnosis based on the following findings, bache? So have a look at the findings. So in the top image, so what are you seeing in the top image, bache? You are seeing that, so this is the left eye of the patient, this is the right eye of the patient. Okay, so you are seeing that there is esotropia. Okay, mild convergent squint in the left eye. Okay, what we see in the middle image, that when the patient is moving to the left gaze, so this eye medial rectus is working, this eye lateral rectus should be working, but this is not moving. That is, abduction is absent in the left side. Abduction is absent in the left eye. And what you see in the image below, now this eye lateral rectus is working, this eye medial rectus is working, means adduction is present in the left eye. Okay, so which muscle is not working in the left eye? Lateral rectus. Which muscle is not working in the left eye? Lateral rectus, because left eye is not able to abduct. And which is the nerve which supplies the lateral rectus, beta? Which is the nerve which supplies the lateral rectus? Absolutely right, sixth nerve. So this is a case of sixth nerve palsy. This is a case of sixth nerve palsy. Now, I always tell in the type of the questions which include your nerve palsies, which include your squint or the movement of the extraocular muscles like yoke muscles, have a quick look at the choices, but then first of all make your own diagnosis and then again come back to the choices to mark the right answer. Okay, right? So all of you agree with this? This is not third, fourth nerve palsy, or of course this is not a case of Horner syndrome because there is no ptosis in these cases, right? Okay. Now, in your last exam, there was a question based upon the third nerve palsy. So, it's very easy to diagnose a case of third nerve palsy because third nerve supplies all the muscles except for lateral rectus and superior oblique. So, when it's supplying all the muscles, so it means there will be weakness of the LPS as well. So, third nerve palsy will have ptosis. So, if you find ptosis, so it becomes clear that which nerve is involved if there is a nerve palsy, third nerve. Okay, and the eye in these cases is in, as you are seeing here, down and out position. Okay, because it's your only superior oblique and lateral rectus which is remaining. The rest all muscles, they have become weak and paralyzed. Okay, so if you see ptosis with eye in down and out position, your diagnosis should be third nerve palsy. Agree, right? And coming to the fourth nerve palsy, which is not as common as the third or sixth nerve palsy, but of course they can ask in the exam about the fourth nerve palsy as well. So fourth nerve supplies your superior oblique muscle. So in those cases, as you see here in the right eye, there is hypertropia. There is hypertropia in the affected side, okay, and there is weakness of the superior oblique muscle. So when the patient is trying to look down, then there is restricted movement in the right eye. So this is a case of right eye superior oblique. Okay, so these patients, they also have head tilt to opposite side, and their diplopia is maximum when they are looking down. ठीक है जी, right? So these are your third, fourth and sixth nerve palsy quick recap. Okay. All right, beta. Coming to the next question, which is again a pretty simple question but an important one because related questions, they can be asked in the exam. So let's do it quickly. Which of the following is not a cause of? So not a cause of. So in question statement, always try not to miss these things, beta, except, not true, false, not a cause. Okay. Of loss of vision in diabetic retinopathy: vitreous hemorrhage, very severe NPDR, diabetic macular edema, tractional retinal detachment. Yes, guys. So which one of these will not be causing loss of vision? Very good, very good. So vitreous hemorrhage, coming to the choices. So vitreous hemorrhage, when there is bleeding in the vitreous cavity, so those blood clots, they will be causing floaters as well as many a times sudden decrease in vision. Okay, tractional retinal detachment is again a complication of advanced diabetic retinopathy. So there will be decrease in vision. Diabetic macular edema. So whenever there is macula which is involved, there is going to be decrease in vision. But very severe NPDR itself, if there is no macular edema, it will not cause loss of vision. Okay, so this understanding is important, that all the stages of NPDR, whether it is a mild NPDR or moderate, severe or very severe, if they are not associated with maculopathy or macular edema, there will not be loss of vision. Okay? And as you know, vitreous hemorrhage and tractional retinal detachment, they often cause severe loss of vision, okay, severe loss of vision. And macular edema, mostly it causes moderate loss of vision. Tractional retinal detachment, again severe loss of vision, okay. Vitreous hemorrhage and tractional retinal detachment might require pars plana vitrectomy for their treatment. Diabetic macular edema can be treated, as you know, by focal or grid laser or by intravitreal anti-VEGF injections, right? So that is the treatment based upon what is the clinical picture which you see in diabetic retinopathy. ठीक है बेटा? Okay? All right. Moving to the next question. Again, a very simple question, but has been multiple time asked in your exam, so you cannot skip this one. Which of the following is not true about the condition shown in the given image? So all of you guys, what is the condition shown in the given image, beta? What is the condition shown in the given image? It is your bited spot. So what you are seeing here, how did we identify this? You are seeing a lesion which is in the bulbar conjunctiva, white foamy spot on the bulbar conjunctiva, more common on the temporal side. So it's a case of bited spot, and we know bited spots, they are seen in the cases of vitamin A deficiency, okay. Now here the question which you have to mark is that which is not true about this condition, okay. So coming to the questions, seen in vitamin deficiency, that is true, I already told you. Nyctalopia or night blindness is the first symptom, that is true. Peripheral visual field loss, okay, so that is not a feature of vitamin A deficiency, that is a feature of retinitis pigmentosa. That is the feature of retinitis pigmentosa, beta. Okay, right? So this is not true of bited spot. Corneal cirrhosis, yes, because the next stage, if it progresses to the next stage, that is the stage of corneal cirrhosis. So the answer of this question will be this. Okay, so sometimes the questions, they can be asked in a trick manner. So please do not forget, just don't jump seeing bited spot to vitamin E deficiency. First read the statement and then mark your answer. Okay, right? Yeah. So what are the triad of retinitis pigmentosa? That is optic disc pallor, bony spicules, okay, and arteriolar attenuation. And this WHO classification of vitamin A deficiency, or which cumulatively is also called as zero ophthalmia, all of you should know, beta. All of you should know. Night blindness is the first symptom, conjunctival cirrhosis is the first sign, and then bited spot, corneal cirrhosis. Cirrhosis means extreme dryness, which is because of the loss of the goblet cells. ठीक है जी? Right? Okay, perfect. Okay, moving on to the next question, beta. A child diagnosed with squint is being evaluated. Which of the following is not a component of the binocular single vision? Okay, binocular single vision. So what are the options? Fusion, simultaneous macular perception, suppression, stereopsis. Okay, so here, as you know, when the vision development is occurring, there are different grades of the binocular single vision which we are trying to achieve. Okay, so you are trying to, because both your eyes, when they are seeing, there are two images which we are being formed, one for each eye. Okay, so there should be, for an object to be seen properly, there should be simultaneous macular perception, that both eyes, they should have image formation in both eyes and at the macula at the same time. So that is one grade or one component of the first component of the binocular single vision. Then these two images in both eyes, they should fuse together. so that you don't have a double vision or diplopia. So that is the second component of the binocular single vision. And then we also have the human eye also has a capability of stereopsis, that we are able, our vision has a capacity to have a depth perception or three-dimensional vision capacity. So that is your third grade of the binocular single vision, which is stereopsis. So if your vision development in both eyes is normal, then you should have a complete component of binocular single vision. Okay, so but when this vision development is affected because of squint, because of uncorrected refractive error, because of anything which is compromising the vision development, be it congenital cataract, so that will lead to suppression. Okay, and when suppression persists for the long time, then it will lead to amblyopia. Amblyopia. So, of course, C is not a part of the binocular single vision, as you have already told me. Okay? Right? Yes, the test for stereopsis is Titmus fly test. One of the tests for stereopsis is Titmus fly test. Very nice, beta. Okay, ji? So, they can ask you question related to this. And in the recent exam, they asked a question related to this slide which I have put here. So here, if you see, these are the tests which we can do to assess the completeness of the binocular single vision. So these are the slides which are shown to a patient on a synaptophore, to check for the binocular single vision. So if you see in the first slide, beta, in the first picture, that shows that there is a cage and there is a bird. So one eye is presented with the slide of the cage, other eye is presented with the slide of the bird. But what the person will see, the person who has normal simultaneous macular perception, so this is to check your simultaneous macular perception, will see bird in the cage, because both eye simultaneously the image is being formed in the macula. Okay, to check for the fusion, two pictures are presented which are partly incomplete, but when both eyes they see them together, it makes it a complete picture. So one eye will be presented a picture of this rabbit which is incomplete, other eye is having the other part of the picture, but when both eyes they see them together, the two images they fuse, so we see a complete picture. Okay, and then the third slide which is presented is to check for the stereopsis, in which you judge that whether there is a depth perception or not. Okay, so this was asked in one of the exams there, I think in the NEET PG recently, so be aware of this, beta. Okay, right? Okay, great, my friends. Moving on to the next question, beta. Moving on to the next question. Again, an often asked question. This was asked in your last exam as well. This has been asked multiple times. So let's not skip it, so that if this comes, this should never be wrong by you. Okay. A boy got hit with a cricket ball in the eye, following which he developed swelling around the eye and diplopia. Okay. So injury with the blunt object, cricket ball, blunt trauma, swelling around the eye, double vision. On examination, there is periorbital ecchymosis. Periorbital ecchymosis means bruising around the eye and restricted eye movements. Radiological examination shows the given findings. Which of the following could be seen in these cases? Which of the following could be seen in these cases? So I'm sure all of you have got that what we are talking about. Okay, injury with blunt trauma, injury with a blunt object. Okay, periorbital ecchymosis, double vision, restricted eye movements, and this radiological finding. So this is showing you, as you are already telling me correctly, this is your teardrop sign, because there is a fracture of the orbital floor and the orbital contents, they are herniating into the maxillary antrum, producing a typical teardrop sign. So this is your orbital floor blowout fracture, orbital floor blowout fracture. ठीक है जी. So clinical case scenario or imaging, please keep it in mind. This image has been asked multiple times, beta. So your diagnosis is clear. Now, what is the question asking you exactly about? That which of the following could be seen in this case? So whether it is anophthalmos, exophthalmos, intermittent proptosis or intermittent squint. So when the orbital contents, they are partly herniating into the maxillary antrum. So it means the volume in the orbit will reduce. So eyeball will go inward, right? ठीक है ना? Part of the contents they have gone into antrum. So eyeball will go inward. There will be inward displacement of the eyeball. ठीक है बेटा? So that will be causing anophthalmos. So orbital floor fracture is one of the common causes of anophthalmos. Correct? Exophthalmos is seen in the cases of beta, mostly it's thyroid eye disease. The proptosis which we see in thyroid eye disease is given the name exophthalmos, and as you know, that's the most common cause of unilateral and bilateral proptosis in adults. Intermittent proptosis is seen in cases of orbital varices. ठीक है जी. Intermittent squint can be present in cases of mostly exotropia. Oh, sorry. Intermittent squint is, it can be in exotropia, and then it can also be seen in the cases of myasthenia gravis, because when there is extraocular muscle palsy, so intermittent diplopia and mild squinting can be there. Okay, right? So orbital floor fracture related question, please do remember beta, that should not cause there. But a cavernous sinus thrombosis is basically a suppurative inflammation of the cavernous sinus. Okay, so which mostly comes from, it can come from ethmoidal sinusitis, orbital cellulitis. So in those cases, there is again painful proptosis along with ophthalmoplegia. Okay, so first of all, one eye is involved, but then because the cavernous sinuses of the two sides, they are connected, so other eye involvement can also occur. And in this case, the important thing which you need to remember is that sixth nerve is the first cranial nerve to be affected in the cases of the cavernous sinus thrombosis. Okay, right? Okay, perfect. All right, moving to the next question, beta. Moving to the next question. Again, the question related to, as you know, visual fields. It's very, very commonly asked. One of the question you will definitely get most of the time related to visual field, which is, if your fundamentals are right, very easy to attempt also. So coming to the question, beta. A lady has lost right half of the visual field. Right half of the visual field in both eyes. What is the type of the defect and site of lesion in this case? Okay, so right half of the visual field is gone in both eyes. So first of all, whenever this kind of question statement is there and they have not shown you the visual field defect as such, try to find out what type of the visual field defect they are talking about. Okay, so this is your right eye. In visual field, it's always good to mark it like, you know, the way your right and left is. So this is your right eye and left eye. So they say that right half of the visual field is gone on both sides. Okay, so this type of the defect in which half of the visual field is gone is called hemianopia. When it is the same half gone, we call this as homonymous hemianopia. And when the question is mentioning that it is the right half which is gone, so it means it is right-sided homonymous hemianopia. Correct, beta? Okay, do you agree? Right-sided homonymous hemianopia. And which conditions we see homonymous hemianopia, beta? We see them in the lesions of optic tract. We see them in the lesions of optic tract. And we know that homonymous hemianopia, so any lesion from optic tract onwards, the type of the defect is contralateral to the site of the lesion. Means if it is right-sided homonymous hemianopia, it means it's the left optic tract which is involved. If it is left-sided homonymous hemianopia, it is the right optic tract which is involved. Okay, so the lesion is always on the contralateral side. Similarly, even the occipital lobe lesion, if it is right-sided hemianopia, the lesion is in the left occipital lobe. Okay, but the difference between the optic tract hemianopia and occipital lobe is occipital lobe mostly has macular sparing. Okay, so again in visual field type of the questions, first come to your own answer and then check your options. So we decided it is right-sided homonymous hemianopia, left optic tract, as nearly all of you are telling me. ठीक है जी, right? So optic field, the visual field related question can come in different forms, beta. In different forms. Sometimes they show you the defect, they ask the site of lesion, sometimes they give you the site of lesion, they ask you about the defect. So please be ready. This is a quick recap of the different visual field defects. Now, as you know, if the lesion is in the retina, so that will cause, depending upon if it is the central macula is involved, that causes macular scotoma or central scotoma. Okay, but here we are starting from the lesion in the optic nerve. So if the lesion is in the optic nerve, then there will be monoocular vision loss on the same side, one side, but okay, so monoocular visual field loss will be there in optic nerve lesions. Okay, if the lesion is in the central part of the optic chiasma, as it is marked here, because it's the nasal fibers which are being affected, then it will be causing bitemporal hemianopia, that the temporal half of both eyes is gone. Most commonly, it is your pituitary tumors like pituitary adenoma or craniopharyngioma, which cause compression of the central optic chiasma, leading to bitemporal hemianopia. Okay, and if lesion is in the optic tract, as we see in C over here, then as we just discussed in the case homonymous hemianopia, if you see here in the part C, here it is left-sided homonymous hemianopia. So it will be homonymous hemianopia in optic tract lesions. If the lesion is in the parietal lobe, that will be causing pie on the floor or inferior quadrantic defect. Okay? If the lesion is in the temporal lobe, then it causes pie in the sky or superior quadrantic defect. Okay? Temporal lobe lesions. And if the lesion is in the occipital cortex, it again causes homonymous hemianopia, but with macula sparing, as you see here. Okay? So simple chart to remember, and this will tell you about all the types of the field defects and the type of the site of the lesion. Okay? So if you want me to kind of complete your notes here, I can do this. Optic chiasma for this one. Okay? So that when you get the PDF, everything is ready for you. Optic tract. So optic radiations in parietal lobe, pie in the sky. Optic radiations in temporal lobe, pie in the floor for parietal and pie in the sky for temporal lobe, and macula sparing homonymous hemianopia in occipital cortex beta. Okay, ji? All good for you? Yeah, the Mayer loop is in temporal lobe and the bomb loop is in the parietal lobe. Okay? Great. All right, bache. Chale. Perfect. Moving to another question over here. Moving to another question over here. A 1-year-old child presents with leukocoria and squint. On fundus examination, the following findings are seen. Ultrasound B scan shows intraocular calcification. What is the likely diagnosis? Okay. Again, in question statement, everything has been given to you. The age group of the child, 1 year. Leukocoria and squint is the presentation. Fundus finding, what the fundus is showing you? Fundus is showing you there is a mass in the retina. Okay. Appearance of the mass is like a cauliflower like mass which is growing into the vitreous cavity. Okay, and they already told you in the question statement, ultrasound B scan shows intraocular calcification. So cauliflower like mass, intraocular calcification is highly suggestive of retinoblastoma beta. ठीक है जी, retinoblastoma. So you know it's a case of retinoblastoma. So question based upon retinoblastoma can be there with all this kind of the presentation beta. Please remember the other options, total retinal detachment. It can cause leukocoria, that's fine, but you do not see a total retinal detachment in this case. Congenital cataract, again it can cause leukocoria or the white pupillary reflex, but in those cases retina will be normal. Optic nerve glioma. Optic nerve glioma is a tumor of optic nerve which is usually present in the cases of neurofibromatosis type 1, von Recklinghsen disease. Okay, right? So this is a typical case scenario with typical fundus presentation in the cases of retinoblastoma. Okay. Yeah, in retinal detachment there will be curtain-like shadow, but you do not expect a 1-year-old child to tell us about the curtain-like shadow. But yes, that's a good point for rhegmatogenous retinal detachment cases as such beta. Okay, so few more things related to retinoblastoma. So sometimes they can give you this picture, so you know there is leukocoria here, and there will be other things in the case statements to tell you about the retinoblastoma. Histopathology of retinoblastoma, the question can be asked based upon Flexner, Wintersteiner rosettes because they are most specific of the retinoblastoma if they are found on histopathology. The investigation of the choice, though it can be investigated with ultrasound, with CT scan, is your MRI scan because that does not causes radiation exposure to the child. Okay, and also tells us about if there is presence of optic nerve invasion or not. Okay, the treatment, you should remember, when it's a large advanced tumor, what we call as group E tumor, in which it is filling more than 50% of the globe or there is anterior segment involvement, then enucleation is the treatment. From group A to D, which includes your small tumors, okay, so it can be focal treatment if the tumor is small in size and in one area. It can be focal treatment plus cryotherapy. When the tumor is bigger, you reduce it by giving chemotherapy, which is known as chemoreduction, and then you can give focal therapy, which can be laser or cryotherapy or brachytherapy or thermotherapy. Okay, so group A to D type of the tumors, focal treatment plus minus chemotherapy depending upon whether it is usually type C and type D, they require chemotherapy as well. Okay, right beta? ठीक है जी? Okay, perfect. Let's move on to the next question, बच्चे. Let's move on to the next question. Identify the test shown in the given image. Identify the test shown in the given image. Let me just enlarge this picture for you. So have a look. This patient is getting a test done in the right eye. So what is the test being done? So very easy to identify. If you see here, bache, if you see here, doctor is holding a syringe in the hand, okay, and this syringe which has a cannula is inside the punctum on the lower lid. Okay, so this is the test or the procedure of lacrimal syringing. Lacrimal syringing, very good. Okay, so Sharma test. Sharma test is a test which is done in cases of dry eye, in which we use paper strips, Whatman paper number 41, to check the quantity of the tear production. Okay, corneal reflex test. Corneal reflex test is done using a cotton wisp. For cotton, you touch the cotton with the cornea to check for the corneal sensations. Okay? And exophthalmometry is a test which is done for measurement of proptosis. Okay? Right? So this is your lacrimal syringing, and very nice corneal sensations. It's your trigeminal nerve which is responsible for the corneal sensation. So corneal reflex test is done for checking the function of the corneal, the cranial nerve as well. So what is 26 gauge, beta? Here we are not using the 26 gauge needle. Here there is a special cannula. There is a special cannula which is used for, because it has to be a blunt cannula. Okay. Yeah, right. Yes, the Hertel's exophthalmometer is the one. Okay. So this is the interpretation of the syringing. A quick review over here. So when you are putting this cannula into the punctum, so you can check both punctum, lower punctum, upper punctum. So usually we start with the lower punctum because it is easy to do from that area. Okay, so this contains a saline. Okay, so you try to advance your cannula from the punctum and then push the fluid there. Okay, so if the fluid, so the lower picture, so if the fluid which you have pushed goes nicely from the punctum to the canaliculi into the sac and the nasolacrimal duct, and the patient will have fluid in the throat, so it means it's a patent passage. It's a patent passage. Okay? But if the fluid partly regurgitates through the opposite punctum and partly it goes into the throat, so then it's a partial obstruction. Then it's a partial obstruction of nasolacrimal duct. Okay? Then over here, if patient does not feel any fluid there and whole of the fluid it comes from the opposite punctum, it is a total obstruction of the nasolacrimal duct. But in these cases, you are able to advance the cannula up to the lacrimal sac area. So once you have gone to the lacrimal sac area, the cannula does not go any further. So we call it as a hard stop because you touch the bone. Okay, so you feel a hard stop, and then you also feel that when you inject, you do the syringing, the fluid is coming from the opposite punctum. So a hard stop with fluid coming from the opposite punctum means total obstruction of the nasolacrimal duct here. Okay, whereas if you encounter a soft stop means the tissue feel is like of a soft tissue, but cannula is not advancing any further, and there is again regurgitation from the opposite punctum. So that indicates a canalicular obstruction. That indicates a canalicular obstruction, that you are able to pass to the common up to the common canaliculus area, but not any further. Okay, whereas normally it should go up to the NLT. And the last is when that canaliculus itself is obstructed. So if you are testing the lower through the lower punctum and the fluid comes back from the lower punctum itself, it means it is lower canaliculus which is blocked. Lower canaliculus. Whereas in the second situation, I should also add common canaliculus, that you have reached up to the common canaliculus. ठीक है जी. So this is the interpretation of the syringing, which sometimes can be asked, and based upon that you have to make a diagnosis that what type of obstruction is there. Okay. So I'll just go through that once more with you. So now we start from the A here. So if you put the cannula into the lower punctum and try to advance it, you are not able to advance it, and the fluid comes back from the same punctum. So here we are checking for the lower, it means it is lower canaliculus obstruction. ठीक है बेटा. In B, you are able to push the cannula, but you encounter a soft stop that you cannot push it any further now, and the fluid comes from the opposite punctum, like from the upper punctum here. It means it's a common canalicular obstruction. ठीक है. If you come to a hard stop, that you have pushed your cannula but then you feel a bony stop and you cannot push it any further, and when you push the syringe, the fluid comes from the opposite punctum, it's a total NLD obstruction. Okay. If you come to a hard stop and when you push the fluid, part of it goes into the nasal cavity and part of it comes from the upper punctum. It's a partial obstruction of the nasolacrimal duct. Okay. And if everything is normal, you are able to push your cannula completely, and when you push the fluid, there is no regurgitation and the fluid goes into the nasal cavity, and then the patient can feel it in the throat, then it's a patent lacrimal passages. Okay. So this is the idea of the syringing we need to do, and you know, when there is NLD obstruction, you need to do DCR. For common canalicular obstruction, we do conjunctivo DCR. Okay. So question based upon the DCR can also occur. Yeah, that's right. Okay. It's not 26 gauge beta, it's a blunt cannula. It's a blunt cannula. Okay, so here are two words from me beta. So you all are proceeding in your preparation towards your success, because they say the talent or a great mind just contributes 1% to the success. 1% is your luck. You are getting in your exam the type of the questions which you have prepared well. Okay. But 98% of your success is going to be based upon your consistency, your perseverance, never giving up. Okay, that's what you are doing. I'm so happy with the type of the answers you are giving me, that with this thing in your mind, that you are not going to give up this momentum, you are not going to give up this sincerity in your hard work, persistence in your hard work till your exam day, and that is the recipe for your success beta. Okay. All of you are talented. I wish all the best to you guys, that you are luckiest on the day of your exam, but the maximum contribution is going to be by your never giving up attitude beta. Okay? And we also are not going to give up and going to move further with our questions here. Moving on to the another clinical case scenario question, bache. Another clinical case scenario question. All right. So please read the question statement here. A patient presents with decreased vision. Decreased vision, yes, you will all pass with the flying colors. I'm 100% sure. Okay, beta, moving on to the next question. A patient presents with decreased vision and hazy cornea 1 month following the cataract surgery. Okay, so there is a history of the cataract surgery, bache. Okay, ji? On examination, there are seen following findings in the eye. So there is a slit lamp image shown to you. The fellow eye means the other eye, also shows corneal guttata. So that's the another finding for you. Which of the following is the cause for this condition? Which of the following is the cause for this condition. So let's have a look at the findings over here. So what do we see here, beta? What do we see here? You are seeing that the cornea is hazy, edematous, and it is showing small bullae on the surface, small blisters on the surface. So this is your Fuchs endothelial dystrophy, especially when they have already told you that there is corneal guttata. So corneal guttata, they are formed when there is loss of the endothelial cells and there is pleomorphism of the corneal endothelial cells. That leads to corneal guttata. So as all of you are right, it's a Fuchs endothelial dystrophy. Now, if a patient has Fuchs endothelial dystrophy, the trauma due to cataract surgery can lead to early decompensation of the cornea, leading to bullous keratopathy, Okay, so it's very important that if you are suspecting Fuchs endothelial dystrophy, one should do a test of specular microscopy in these patients before attempting cataract surgery, so that you know if the endothelial cell loss is very severe. In these patients, you should combine cataract surgery with corneal transplant. ठीक है बेटा? So this is the information. Now other options: post-operative endophthalmitis, Irwin gas syndrome, posterior capsular rupture. Of course, they do not fit into this criteria. Now something about these other choices, because complications of cataract surgery is beta again an important topic for you people. So post-op endophthalmitis, as you all know, the acute post-op endophthalmitis, which is the most common organism involved in acute post-endophthalmitis, that is your staph epidermidis, which is also your normal commensal on the conjunctival sac. Please remember this. So in these cases, there will be painful red eye, decrease in the vision, there will be suppurative inflammation in the anterior chamber as well as in the posterior cavity, vitreous cavity, leading to decrease in the vision. Okay, and then what is Irwin gas syndrome, beta? Irwin gas syndrome. Last time the question was there based upon this as well. So Irwin gas syndrome is development of cystoid macular edema after cataract surgery. Right? So these these are some other complications of the cataract surgery. Okay. Whereas if there is rupture of posterior capsule, the posterior capsule rupture is an intraoperative complication, and in those cases then sometimes you cannot place the posterior chamber intraocular lens and you might need to implant anterior chamber intraocular lens. Okay, right? All right, bache. Moving on to the next question, beta. Identify the muscle acting in the left eye in the gaze shown in the given image. Okay, so tell me the muscle which is acting in the left eye of this patient. So this is the left eye, this is the right eye. This is the left eye, this is the right eye. So which muscle is acting in the left eye? Okay, so which is this gaze here, beta? Which is this gaze here? So patient is looking right and up. So patient is looking on the right side and up. So it is right and up gaze, or what we call as dextro elevation. Okay? So very good. So when it is dextro elevation, the rectus of the same side, so it is in the right eye, superior rectus, and oblique of the other, the yoke muscle will be the oblique in the other eye. So in the left eye, it is your inferior oblique which is acting. I'm so happy that all of you are telling this as a right answer. Perfect. So this is a pair of the yolk muscles which is acting in dextro elevation, right eye superior rectus and left eye inferior oblique. Okay, so you can get a question based upon this beta, that they tell you a gaze and then you have to tell the yolk muscles. So you know yolk muscles are the muscles which are moving the eye in the same direction, one muscle in each eye. Okay, whereas synergist muscle is the muscle in the same eye. Okay, synergist muscle is the muscles in the same eye for the same movement. For example, if we talk about the adduction, then medial rectus and superior rectus will be synergist muscle, whereas yolk muscle are one muscles, it's a pair of one muscle in each eye moving the eye in the same direction or same gaze. Right? ठीक है जी? So do not get confused between the yolk muscle and synergist muscle, and you know. Alright, perfect. Moving on to the next question, beta. Moving on to the next question. So this is again a clinical case scenario question with a fundus image here. So question is, an infant presents with developmental delay, muscle weakness and history of seizures. So it's a small baby, an infant, having developmental delay, muscle weakness and history of seizures. The fundus examination is as shown here. What is the diagnosis? What is the diagnosis? Okay? So have a look here, beta. What do you see in the fundus image here? So you can see there is a bright red spot in the macula, like a cherry. Okay? So it's a cherry red spot. It's a cherry red spot seen in macula in both eyes. Now with the history in which there is muscle weakness, developmental delay in an infant, so what is your diagnosis? Is it a Stargardt disease, central retinal artery occlusion, Tay-Sachs disease or Best disease? So as all of you are telling me absolutely right, it is your Tay-Sachs disease, beta. Okay, so you know cherry red spot is present in nearly 90% cases of Tay-Sachs disease, and this is the systemic features there, so you must be aware of this, bache. Stargardt's disease is the type of retinal degeneration, hereditary retinal degeneration, in which you see bull's eye maculopathy. So Stargardt disease is one of the cause of bull's eye maculopathy. In central retinal artery occlusion also we will see the cherry red spot, but I'll just show you that has a different fundus picture. Okay, and in Best disease, again a hereditary retinal degeneration in which we get egg yolk appearance. In that we get egg yolk appearance, bache. Remember? ठीक है ना? Right. So this is how central retinal cherry red spot in central retinal artery occlusion will look like. Okay, so there is a cherry red spot, but then there is pale ischemic retina because of the artery occlusion, and mostly there is a risk factor of hypertension or some embolic activity, embolism, atherosclerosis, so that risk factor will be there, and sudden loss of the vision on the fundus examination, pale ischemic retina and cherry red spot. So that is a case of central retinal artery occlusion. ठीक है जी? Yeah, absolutely right, Dr. Yasir Khan. Chloroquine toxicity is another important cause of bullseye maculopathy. Absolutely right. ठीक है बेटा? Right? Yeah, great. So do remember the differential diagnosis of the cherry red spot, beta, and there is a very popular mnemonic to remember the differential diagnosis of cherry red spot here, that Christmas tree never grows tall in sand and mud. So, oh, make a correction here, beta. It should be CRAO. So I'm just correcting over here. The Christmas is for your CRAO, central retinal artery occlusion. Then Tay-Sachs disease. So among the lipid storage diseases, Tay-Sachs disease is the one which is most commonly associated with cherry red spot, though it can be present in Niemann-Pick disease, Gaucher, Sandoff also. Then trauma, blunt trauma, it causes Berlin's edema, in which again you see a cherry red spot in the macula. And then of course metachromatic leukodystrophy. Okay, so this is the DD of the cherry red spot, bache. Yeah, absolutely right, Weber. So I just realized that it was typed as a CRVO. So this is not CRVO. This is CRAO, central retinal artery occlusion. Absolutely right. ठीक है जी? Okay, moving to the next question, beta. Moving to the next question here. A 5-year-old girl with squint underwent retinoscopy under atropine and at 1 meter working distance. So what is the glass prescription in this case? So let's solve this. Okay, so we have done this many times. I'm sure you have practiced it many times. So this is the retinoscopy. So the child had squint. So this was performed under atropine and the working distance given to us is 1 meter. So as all of you know that when we are looking at the retinoscopy, you have to make correction for the working distance, and if there is any cycloplegia which is used, you have to make correction for that. Okay, so if working distance is 1 meter, then the correction for working distance will be -1 diopter. And atropine, if it is used for cycloplegia, which is a preferred cycloplegia whenever there is squint in a child. Okay, so 1% atropine ointment is the preferred cycloplegia. So the correction for atropine is also -1. So our corrected cross here should be -1, -1, -1, -1. So this will be converted to, so now it is +4 diopter and +2 diopter. Okay, so after correction, the corrected crosses +4 diopter at 90 degree and +2 at 180 degree or horizontal meridian. Now, always give smaller numerical value as the sphere. So we will give +2 diopter spherical in the glass prescription, so which will completely correct the horizontal meridian. But at vertical meridian, there will be residual +2 still left. So that will be given as the cylinder. So we'll be giving +2 diopter cylinder. And you know, cylinder is to be placed at 90 degree to where it is required. So since cylinder is required at 90 degree, it will be placed at 180 degree. So this will be your glass prescription. Okay, this will be your glass prescription. Dr. Yasir, just see, it should be +2 and +2 diopter cylindrical. Okay, right? So B is your answer here, bache. B is your answer here. Okay, right? I hope it is clear with you. Okay. And if I have to tell you, or you have to tell me that what is the type of the astigmatism which you are seeing here. So what will be the type of the astigmatism? So this will be, there is plus in the sphere, there is plus in the cylinder, so it is compound hypermetropic astigmatism. Agree beta? Compound hypermetropic astigmatism. And whether it is with the rule or against the rule, beta. Whether it is with the rule or against the rule. Why it is with the rule, bache? Why it is with the rule? Yes, Dr. Ayush, you are right. This is against the rule. Against the rule. The easiest thing to remember, beta, is with the rule is when you see minus at 180 in the glass prescription. Okay, so in the glass prescription, when you see, so I'll just write here. So in glass prescription, when it is minus at 180, that is with the rule. Okay, so let me just show you here. So this is a quick way to remember it in your exam, beta. If you see minus cylinder placed at 180 in the glass prescription, that is with the rule, okay. But when in this glass prescription it is plus at 180, so this will be, anything else will be against the rule. Okay, minus at 180 is with the rule, anything else is against the rule. So if it is plus at 180, it means it's against the rule. If it is minus at 90, it means it's against the rule. ठीक है ना? Right? Yeah. So minus at 180 or plus at 90 is your with the rule. Okay, so I hope I am clear with this. Okay, guys. So this was question related to your retinoscopy or refraction. Moving on to the next question here. All right. Okay, Ji. So moving to the next question, which of the following is not seen with travoprost when used to lower intraocular pressure? Again important. Which of the following is not seen with travoprost when used to lower intraocular pressure? So anti-glaucoma drugs, important topic here, bache. So cystoid macular edema, hypertrichosis, lid retraction or iris pigmentation. So travoprost is your prostaglandin analog drug, which is used a first line drug in the treatment of glaucoma. When you want to start a patient on anti-glaucoma drug. So cystoid macular edema is a side effect and rather a contraindication for use of travoprost. Hypertrichosis, that is increase in the number and length of the eyelashes, is seen with travoprost. Iris hyperpigmentation is seen with travoprost, but lid retraction is not a side effect of prostaglandin analogs. Okay, so yes, very right. Epreclonidine and to some extent even brimonidine, they cause lid retraction, beta. Okay, so lid retraction is side effect of. Epreclonidine is not very commonly used as anti-glaucoma. Brimonidine is one of the commonly used anti-glaucoma drug. So both of these are associated with side effect of lid retraction, beta. Okay, so the side effects of anti-glaucoma drug, mechanism of action of anti-glaucoma drugs. So please have a quick recap before your exams, bache. Okay, right? All right, beta. Moving on to the next question, which is again a clinical case scenario question along with an image here. So let's read the question statement. A hypertensive patient has episodes of emerosis fugax. So patient is hypertensive. Episodes of emerosis fugax. So what is emerosis fugax, beta? When there is transient loss of vision. So patient loses vision for a few seconds or few minutes, but then vision comes back. So that is emerosis fugax. For past 1 week on examination, his visual acuity and pupil reactions are normal. So now when you are looking at the patient, his vision and pupil reactions, they are normal. Fundus findings are as shown. What is the likely diagnosis in this case? So what are the fundus findings? What are the fundus findings which you are seeing here, beta? Any fundus image, first of all, look at the optic disc. Look whether the color of the optic disc is normal or not. So this is appearing more red. So there is a hyperemia of the optic disc. Okay. Do you see the margins of the optic disc clearly? No. The margins of the optic disc, they are blurred. Look at the vessels. The vessels, they are appearing tortuous on the surface of the optic disc. And in the left eye, there is also a hemorrhage around the optic disc. So this is disc hyperemia with disc swelling. Okay, right? So when there is disc hyperemia or disc edema and along with episodes of emerosis fugax, normal visual acuity, normal pupil reactions, so that indicates that this is a case of papilledema, beta. This is the case of papilledema, because especially in early stages of papilledema, there is no change in the visual acuity or pupil reactions. If papilledema persists for long time, when it becomes chronic, then there is change in visual acuity as well as there is RAPT. Okay? So please remember this. Why this is so? Because papilledema is a passive swelling of the optic disc. Okay? Now similar picture can be seen in the disc edema can also be seen in papillitis, optic neuritis. Okay, but then in those cases the visual acuity will be decreased, color vision will be decreased, and there will be RAPT. Okay. Similarly, in anterior ischemic optic neuropathy, when the problem is due to that, visual acuity will be decreased, there will be RAPT. Toxic optic neuropathy, again vision will be decreased and there will be RAPT. And if you remember, one of the important drugs which causes toxic optic neuropathy is your ethambutol. Okay, so here, since it is passive disc edema, papilledema in early stages will cause amaurosis fugax, normal visual reaction, pupil reaction, and the type of the visual field defect which you get in these cases is enlargement of the blind spot. ठीक है बेटा, enlargement of the blind spot. All right, ठीक है? So please remember that. Yeah, so toxic optic neuropathy, very right. It can be because of the methanol toxicity, nutritional amblyopia, beta, tobacco, alcohol amblyopia, as well as ethambutol is the important one, which as we already discussed. ठीक है जी? Okay, time to move on to another clinical case scenario question, bache. Okay, let's read our question statement first of all. A lady has been having recurrent episodes of painful decrease in the vision in the left eye with following findings on the examination. There is also development of cataract in this eye now. Which of the following is not a feature of cataract seen in this case? So first of all, have a look at the findings which are shown here. So patient having painful decrease in vision, and these are the findings which you are seeing here. So very classically you are able to first of all notice the irregular pupil here because of the posterior synecdoche. Then you can also notice the keratic precipitates. So you are seeing KPs, irregular pupil, painful decrease in vision. So this is a case of acute anterior uveitis. So patient is having recurrent episodes of acute anterior uveitis. ठीक है जी? Right? Now this patient, if it develops cataract, the type of the cataract which occurs in the cases of acute anterior uveitis is called as complicated cataract, beta. Remember, it's called as complicated cataract. And what are the features of complicated cataract? Now coming to your choices here now. So complicated cataract has breadcrumb appearance, that is true. It has polychromatic luster, that is true. Pseudo-exfoliation is not a feature of complicated cataract. And when complicated cataract is because of uveitis, it is posterior subcapsular type of cataract. So this is the answer which you have to mark line. So C is not a feature of the cataract associated with this type of the condition. ठीक है बेटा? So this question is basically telling you about the features of the complicated cataract and also telling you all the hallmark signs of acute anterior uveitis. Okay, so irregular pupil or festooned pupil because of the posterior synecdoche, keratic precipitates, cells and flare in the anterior chamber, are features of acute anterior uveitis. In granulomatous type, you can also see iris nodules and mutton fat capies. Okay? So please remember the features of acute anterior uveitis as well. All right, bache. Time to move on to the next question here. A very easy one, nearly a spot diagnosis. Nearly a spot diagnosis. A young boy presents with a raised lesion in the eye. There is no pain, there is no redness or pain. What is the diagnosis in this case, beta? Is it a limbal dermoid, a pingicula, phylactanular conjunctivitis, or Herbert follicle? Okay, painless nodule on the eye surface, no redness, no other features. So if you see a raised lesion like this at the limbus, no redness, this is your limbal dermoid, beta. This is your limbal dermoid. Okay, so this question can be asked as an image based question to you. So this is the limbal dermoid, and it is not a pingicula. Pingicula is usually not at limbus. Exactly, it's more on the bulbar side. The appearance of pingicula is a gelatinous lesion. Phylactanular conjunctivitis will cause red eye. There will be discomfort as well, and there will be phylactins. So you see, I'm just going to show you the images for your quick recap as well. Herbert follicles we see in the cases of trachoma in the follicular stage. Okay, so just to have a differential diagnosis of the raised lesions or the lesions which you see on the limbus or on the bulbar conjunctiva. So have a look here, because the question can be asked image based question or clinical case questions like this. So this one is your phylactins, which you see in the cases of phylactanular conjunctivitis, beta. Okay, so yellowish nodules close to the limbus, but then there will be redness in the eye as well, because it causes conjunctivitis, right? This is your pingicula. Pingicula causes a gelatinous type of the lesion. Now this can be close to the limbus as well, but then it's a gelatinous lesion. It's the gelatinous lesion. This image is showing you multiple gelatinous spots here on the limbus. Okay, so these are your Horner-Tranta spots. Horner-Tranta spots, which you see in the cases of VKC, spring cataract. Alright, and here is an image in which you are not seeing any raised lesion, but you are seeing small pits on the limbus. So these are your Herbert's pits, which will occur in the cases of trachoma once the Herbert follicles they have healed. So when the Herbert follicles they heal, they leave Herbert pits. Okay, right? So please do remember that how you are able to differentiate between different similar looking lesions, bache. Great. Chal, very good, very good. I'm so happy with your answers, bache. All right, moving to another question here, another clinical case scenario here, bache. A lady comes to emergency with headache, vomiting, and severe pain in the left eye. On examination, it shows a red eye with mid-dilated pupil, corneal haze, and shallow anterior chamber. What is the diagnosis in this case? Okay, so an ocular emergency in which patient is having severe pain, headache, and vomiting. Eye is showing you red eye, corneal edema, and a mid-dilated pupil. And if you see carefully, there is very shallow AC. So this is a picture of acute congestive glaucoma or acute angle closure glaucoma, beta. Okay, so this similar question had come in your last exam as well. It came in INI-CT exam as well, and has been coming in the NEET PG exam as well. So this has been there in today's session, so that you should not mark it wrongly, beta. Okay, so Why there is severe headache and severe pain? Because intraocular pressure is very, very high. Mid-dilated pupil with corneal edema, shallow interior chamber means there is acute angle closure leading to high intraocular pressure. Okay. How to differentiate it from the other diagnosis, other causes of the painful red eye? In interior uveitis, pupil is myosed or irregular. Okay, as we just saw, it is not mid-dilated fixed pupil. Okay. Viral keratitis. Viral keratitis, pupil should be normal and it causes a dendritic ulcer. Dendritic ulcer. Angular conjunctivitis. Angular conjunctivitis is an inflammation or infection in the conjunctiva, so it won't be causing severe pain or corneal edema or shallow interior chamber. And you know, angular conjunctivitis is seen in the cases of Moraxella, Exenfeld, okay, in which the congestion is more in the canthal areas of the eye. So try to differentiate the different causes of the painful red eye, okay, and look at the specific features which will help you in the diagnosis. Okay, ji? So diagnosis of acute angle closure glaucoma should not be missed by you if similar case scenario comes in the exam. Okay. And even the management of acute congestive glaucoma, beta. Even the management of acute congestive glaucoma, sometimes the question can be based upon that as well. So the first step is to reduce the intraocular pressure, which is very, very high, which is done by giving mannitol and or acetazolamide, that is Diamox. ठीक है, agree? Secondly, हमें क्या करना है? We have to break the pupil block, because when the pupil had become dilated, so that led to the angle closure. So to break the pupil block, we are going to give the pilocarpine, which will constrict the pupil. Okay, and then you can add the other anti-glaucoma drugs once these two steps they have been achieved. Okay, the definitive treatment once the attack has subsided, then you have to do ND-YAG peripheral iridotomy. ND-YAG peripheral iridotomy, making a hole in the peripheral part of the iris to prevent the future attacks of the acute congestive glaucoma. ठीक है बच्चे? So this is what needs to be done in these cases. All right? ठीक है? Okay. Moving on to the next question, बच्चे. Moving on to the next question here. A patient presents with painless nodular swelling. Again, please look at the keywords here. Painless nodular swelling, which is away from the lid margin as shown in the given image. So again, everything has been given to you. Painless nodular swelling away from the lid margin. Okay. So what will be the type of the glands involved in this case? So this is your clesion. I don't think any one of you will miss it. So painless nodular swelling away from the lid margin as shown here. Okay. So what are the glands involved? So clesion is a lipogranulomatous inflammation of the meibomian glands. Absolutely right. So the secretions, they get accumulated there. They are not able to drain. So there is this nodular swelling which appears. Okay. If there is suppurative inflammation of glands of Zeiss or glands of mole, they cause stye beta or hordeolum internum. Then they look like this. So when there is painful swelling at the lid margin, that is your stye or hordeolum externum. So in those cases, the glands which are associated with the root of the eyelash, either it can be gland of Zeiss or even gland of mole, that can lead to stye bitching. ठीक है जी, right? And of course, lacrimal glands, they are, if you talk about the main lacrimal gland, that is in the lateral part of the orbit, so that will not cause a swelling in the eyelid बच्चे. ठीक है? So any question related to clavion and stye also should be very clear to you, I think. ठीक है? Right. Moving on to the next question बच्चे. Moving on to the next question. A diabetic patient presents with decrease in the right eye vision. Okay? So patient is a diabetic, there is decrease in the vision in the right eye, and the fundus examination shows the following findings. What is the next step in the management of this patient? So have a look at the fundus. Have a look at the fundus. So here again the same rule applies. So you look at the optic nerve. You look at the optic nerve. Optic nerve is appearing normal here. The vessels on the optic nerve is appearing normal. So coming to the macular area, what you are seeing here, there is deposition of these lipid exudates, that is hard exudates. If you see very carefully, these are these red spots, the microaneurysms which you are seeing here. Okay, so microaneurysms, lipid exudates seen in the macular area. So this is a case in a diabetic patient. It is the case of diabetic macular edema. Diabetic macular edema, correct? So what will be the next step in the management of this patient? Will you do perimetry? Perimetry is the visual field examination. Will you do optical coherence tomography? Will you do ultrasound B scan? Or you will do ERG? Okay. Of course, you will do optical coherence tomography because that is the investigation of the choice for macular diseases. Perimetry is for visual field. Ultrasound B scan we do when we are not able to visualize the fundus, for example, in cases of vitreous hemorrhage or total cataract, or in the cases of intraocular tumors. ERG, electroretinogram, is done for diagnosis of retinitis pigmentosa. So optical coherence tomography is the one which you want to do for diabetic macular edema, age-related macular degeneration, CSR, so all diseases of the macula. So this will be the OCT or optical coherence tomography in the patient which we just saw. So because of the edema, because of the collection of the fluid, as you see here in the spaces here, and these are your lipid exudates, beta. So you can clearly see how much is the thickness which has increased, how much is the edema, and you can even follow the progression of the patients once you treat it. And for your reference, I have put a normal OCT picture also here, normal OCT scan. So this one is a color coded picture, beta. This one is a color coded. So it can be a color coded scan, okay, like there where they give color to the different layers of the retina, okay, or it can be the type of this black and white picture which you saw, we call it as a grayscale scan, beta, grayscale. Okay, so this color coding is a false color coding, bache. Okay, yeah, cyst on macular edema can cause honeycomb and flower petal appearance, honeycombing on fundus examination, and flower petal on FFA. Absolutely right, bache. So happy. So this is your normal OCT scan. As you see all the layers which are normal, and exactly you are able to see all the retinal layers like a histopathological section. So in vivo, the last INICT exam, they asked that what investigation shows you all the retinal layers in vivo. In vivo means in the live patient. So OCT shows you all the layers. Okay. So this one, this side is your choroid. This is your RPE. This is the area of the fovea, and all the layers, all the different layers of the retina, all the 9 layers, they can be visualized on the normal OCT scan. Okay, beta, right? Okay, ji. Coming to your last question for the discussion here, bache. Last question for the discussion here. Which of the following has no role in cataract surgery? Which of the following has no role in the cataract surgery? Choices are LIMS forceps, 10-0 nylon suture, 5% povidone iodine solution, excimer laser. So which of the following do you think has no role in cataract surgery? So LIMS forceps is your corneoscleral forceps. Corneal scleral forceps. So of course, if you want to hold the tissue, then corneoscleral forceps needs to be used. Okay. So 10-0 nylon suture is again the sutures which is used for cornea, especially when you are doing conventional ECCE surgery in which there is a large incision. Okay. 5% povidone iodine solution is beta best prophylaxis. It's the best prophylaxis against endophthalmitis. Okay, so before you do the surgery, you prepare the eye by using 5% povidone iodine, or what is also called as betadine solution. Okay. Excimer laser has no role in cataract surgery. The type of the laser which is used to assist the modern day cataract surgery is femtosecond laser beta. Femtosecond laser. Okay. Excimer laser is used for LASIK. Excimer laser is used for LASIK beta. Okay. No, not for after cataract. For after cataract, we are using ND-YAG laser. ND-YAG laser is used for capsulotomy beta. Okay. For in PCO or there. Okay, bache? So questions related to cataract surgery again very important. Okay. So just to show you they can ask you instrument also. This is your LIMS forceps. This is your LIMS forceps. So LIMS forceps has these very fine teeth with which you can hold a corneoscleral flap or the corneoscleral tissue. Okay. And then as I told you, preoperative povidone iodine antisepsis. So 10% solution is used around the skin area, and then 5% solution is used to be put in the conjunctival sac. So that is the best prophylaxis against endophthalmitis. And the type of the laser which we use, we just discussed. Excimer is for LASIK. Femtosecond laser is used in cataract surgery. And in case you want to treat a case of PCO, posterior capsular opacification, or after cataract, then you use ND-YAG laser. Okay? Alright. So this was your today's sessions where we have discussed lot of questions, we have discussed lot of topics, and I'm very happy most of you have almost all of you have your fundamentals very, very clear. Okay, so keep these fundamentals clear in your exam as well, beta. As far as ophthalmology is concerned, the type of the topics which we have covered, you can expect your questions from this. Of course, the exact question, whether the examiner is asking about a diagnosis or about a management or about a complication, can vary, but do not miss these topics. Okay. And at the same time, keep your mind open, try to recollect what you have read, try to stay calm and do your best in your exam, bache. Okay? So, I want you to be a dhurandhar. So, everybody is becoming a dhurandhar. So, we as a doctors, to clear your exam, I want you to be a dhurandhar in your preparation as well as in your exam. ठीक है जी, right? So all the very best from the MIST team. Keep your momentum going. Do not lose it. You are doing your best, beta. Just stay in a very positive frame of mind. Keep learning. Be persistent, and all of you are going to succeed with flying colors. Okay. All the very best to you. Take care of yourself and We will see you soon with great results in your hands, बच्चे. ठीक है जी? Right? Okay, beta. Okay. Thank you so much for being such a interactive session. It has been really wonderful. Take care of yourself, beta. Yes, of course, the PDF will be shared with you. I'm going to share the PDF with our Miss team, and they will be putting that for your use, bache. Okay? All right, beta. Perfect. Thank you so much. Take care of yourself. Give yourself some rest, and then be ready to revise your topics, whatever you are doing. All right. Perfect. So I'll take your leave here. God bless you, beta. God bless all of you.